Right, thank you again for the introduction. Yes, and it's on the same theme as we've just been hearing. It's I thought the best thing to do is just to show some cases that we're using the right equipment and the right balloon to allow you to cross uncrossable lesion and CTOs would be very helpful. These are my conflict of interest. The patient, I'm going to present two cases to you. Just show you quickly how we use these balloon. The first one was 65 years old with type 2 diabetes mellitus and hypertension. He has had a previous bypass operation in the past with Lima to LAD, radial artery to OM, and vein graft to PDA. He presented with acute coronary syndrome and had a repeat angiogram with the graft. There was a severe mid-LAD disease, then the SVG to the PDA was severely diseased before insertion. Both were treated with PUPA, and my colleague who treated him spoke to me about the SVG, because quite often for the last few years, I have advocated not to treat the vein graft anymore and just to try to open the native artery if possible in certain circumstances. And this was one of them, because once the vein graft starts going, it will go, and it's better to recanalize the native artery. So I did this case as a live case demonstration of retrograde approach. As you see, this is the setup shots, and this is a guiding catheter into the vein graft. Because still it's disease, but it is patent with the stenosis where the balloon was used. And we went to the retrograde approach. The occlusion area was probably about 20-25 millimeter and heavily calcified. We managed to cross retrogradely, but the retrograde wire would not go. So we injected through the tip of the microcatheter just to see what we're dealing with. And you could see how much calcification, because you'd see it from even without injecting the dye. Anyway, at this stage, I thought the best thing to do is to go antegrade also, aiming to do a reverse cart. A reverse cart, which means you go antegrade and introduce your balloon to connect the retrograde and the antegrade gear. At this stage, we went antegrade with another microcatheter, and I managed to do what's called a tip in. So the antegrade wire, which was a confianza, because the lesion was quite resistant, the confianza wire went through, and I managed to introduce it into the tip of the retrograde microcatheter, as you could see on the picture on the left side. Then advanced the microcatheter, advanced the wire all the way back and retreated the retrograde microcatheter and the antegrade microcatheter also. And of course, at this stage, it should become like a normal angioplasty. I was expecting difficulties because of the heavy calcification and the inability to deliver the microcatheter forward, because the plan was to deliver the microcatheter, exchange for a rotawire and rotablate. So what we needed to do in order to do this, because I did not want to lose my position, is to create a channel to be able to deliver the microcatheter and the rotablation wire. So what we did here on the left side, we took the Alveo balloon. We tried a couple balloons, to be honest, before, because quite often what we used to use is the Abbott, the Minitrek 1.2. That's the smallest diameter. We do have also the Sapphire 1.0 balloon, and we do have the Crosset balloon, which is 0.85, but it's quite a very flimsy balloon to a certain degree. It doesn't cross all the lesion. Alveo, in this case, after I tried the two, I managed to get to the Alveo balloon across and inflated it to 20 atmosphere. And at that time, I was able to move it up and down. So I thought we'll do what we call usually granuloplasty. So I ruptured it on purpose in that lesion just to create some kind of fracture to allow me to deliver the microcatheter. Once that's done, it became very easy to deliver the microcatheter forward and then exchange to the rotawire and perform rotablation, as you can see on the right panel. And once that's done, pre-dilatation performed and stents inserted. And as you can see here, and we achieved a very good result. Here's the post-dilatation, and this is the final result of the, of course, something controversial. Some people do it, some people don't, which is coiling the vein graft. In this case, I inserted a vascular plug, as you can see it there on the left side panel, because often if the vein graft is left, the competitive flow could lead to thrombosis or restenosis. But anyway, this was a case where I think having tried, of course, I could have used laser, but with the heavy calcification and we were there, I think the Alveo balloon has made life much easier and allowed me to deliver the microcatheter to exchange for a rotawire and perform rotablation. So the second case I'm going to share, the same thing, he's 65 years old with history of atrial fibrillation and hypertension. He has had CVAs before, but good recovery. Presented with troponin positive ACS. He had an angiogram which showed severe LAD and dominant circumflex disease. He was referred for the JCC and MDT discussion and was accepted for PCI because of his CVA, and he also himself did not want surgery. This is his setup angiogram. You could see from the outset that his LAD is quite really tortuous, and you could see the calcium even before particularly in the mid part of the LAD. But here you're faced with really difficulty on many levels. There is severe stenosis proximally, which will create a lot of friction if you are going to deliver anything distally. There's a lot of tortuosity, which again will make life difficult to deliver. And the same thing with these are frozen. The same thing with the mid-course disease and the calcium, which also will be quite resistant. So anyway, I accepted his case and brought him into the cath lab. After a bit of struggle, we managed to get a Fielder XTA to start with, just into the nose of the CTO, but the microcatheter would not go. So I changed to a Gaia third to be able to get through it. But of course, we managed, as you can see in the middle panel, the wire went down more, but the microcatheter will not go. So we took the microcatheter as far as it will go, and then used a Gladius MG wire, because nothing else would go, to allow me to remove the Gladius out for two reasons. Number one, it's stiff. I don't want any problem distally, particularly when there's any resistance to the wire could move back and forth. And also because of the radio opacity, it makes it difficult to see what lesion you're dealing with on the artery. So that the Gladius MG went distally. And now that struggle become more relevant because I could not deliver any balloons or any equipment, obviously. The proximal lesion needed to be treated with the high pressure non-compliant balloon. And despite that, it was still tight, but I managed to get a guide liner down. And the guide liner allows me also, the plan was to take a laser catheter because I didn't think I was able to put any rotablation down. So as you could see in this third, and the one on the right, we managed to take the Alveo balloon in the middle. And again, nothing else, having tried 2 or 3 different balloons, nothing will go, and managed to get the Alveo balloon through the occlusion and inflate it to high pressure. And once that's done, I knew that I needed to do something more. And that's where we took the laser. We took the laser for the proximal part because the balloon, if I go back up again, if you see these, let me just play this. The balloon is quite restricted in here. Oh, this is not frozen now. Let me just try that again. Okay, this one here. Apologies, this is the balloon. Anyway, maybe this one here will show it. You could see that there's a waist on the balloon. I don't know if that's clear or not, but there was a severely narrowed area that did not expand despite going to higher pressure. And that's where the laser also came to help. So the Alveo allowed me to go through distally. And then I took the lasered that under expanded area that did not expand with the high pressure non-compliant balloon, then also lasered all the way to the distal RCA to LAD to allow me to pre-dilate and deliver stents. Delivering stent was quite difficult. We ended up having to use a shockwave in the proximal part and stent the proximal part first, which is often not what we do, but if you have to do it, that's what you do. And using the guide liner allowed me to go down a little bit further. Here we're performing pre-dilatation, and then that's after pre-dilatation. You can see the proximal lesion still a little tight, but we stented it first in the mid segment, and then after that, with the support of the guide liner, step by step, we went from the mid distal LAD because the artery was heavily diseased from top to bottom, then a second stent, then a third one, as you can see in here. And post dilatation, and this is what we were left with. I think having achieved open the artery, it's a huge artery, 4O, approximately 3.5 in mid-vessel with dilatation, and this is how this was left. I think if I would have struggled enormously to be able to deliver through these really tight occlusion, basically, nothing will go. But the Alveo balloon allowed me, because it's a low profile, high pressure balloon, which is very helpful in uncrossable lesion. And that allowed me to facilitate other steps to complete lesion debulking and performing the procedure and having a successful outcome. Now, I suppose there's a lot of, thank you very much. This is the last slide. I'll just say, I mean, there's a lot of equipment and a lot of, stop sharing here, a lot of equipment, a lot of balloons, and everybody tells you the balloons are good and this and that. But I think experience tells us that there are few on the market that will allow you to perform good or achieve good outcome. Alveo is one of them. No equipment is going to always be 100% successful, but it's the percentage of success what makes you really lean toward one thing or another. And I think Alveo, for me, having tried it now a few times, it has served me very, very well and allowed me to complete some complicated and difficult cases. And with this, I'll just be happy to hear any comments or any questions.
That is a very, very nice case, nice two case. For the first case, do you regular coil the vein graft when you open the native artery? I have no experience to coil or block those graft.
I have to say my practice has been the majority, except in one or two cases I did not coil them, but the majority of them, if I am happy with the outcome of the native artery and I don't see any issues, yes, and I usually coil them. And one or two occasions where the flow in the distal vessel was not very good, or you needed kind of, if I wanted a good outcome, to put a full metal jacket, which I did not think that was the right thing to do. I left the vein graft, but I usually coil them and block them completely because they become redundant. And I think the kind of turbulent flow, to my mind, probably causes more problem than benefits.
Because when I implant the stent at a very high pressure, at the anastomosis side, the graft is tendency to block itself later.
Yeah, I mean, there is that argument. I mean, I suppose if you see a diseased graft, quite often they'll go down. And this is my motto. I always say, once they start going, they will go. And this is why I probably haven't done a vein graft intervention for a very long time, unless it's acute MI, where I will treat them with a balloon or maybe a stent. I'll bring the patient for opening the native artery, because I think that's more sustainable and more longer term, better outcome. But yes, some people say if you put the stent across, it might stop the flow. I've done that on a few occasions, but then I found out they could come back with problems. So I always coil them now. There is a study ongoing right now. Recruitment is ongoing from Europe and America to look at this particular subject. Do you coil? Do you not? I think it's going to be very difficult because recruitment is very slow, obviously, as you could imagine. And but hopefully it will give us some information, some insight in whether to coil or not.
Okay, so very great case again. First case, I'm under impression about the way of using granuloplasty. Really nice idea. And the second case, I have a question. I know you are a fan of laser, as I heard, but what do you think about using, in this case, orbital atherectomy? I know that it's not so efficient in front lesion, uncrossable lesion, as rectal ablation. However, in this case, there were much bending, yeah, so it was toxicity of the vessel. So maybe, how do you think, if you can compare the laser with orbital atherectomy in these cases? I have no experience with laser.
Yeah, I mean, certainly you can use orbital atherectomy. The only thing I would say is, in order to use orbital atherectomy, you need the Viber wire. The Viber wire is not the same as the normal angioplasty wire. Yeah, and as you saw, I was struggling to get the microcatheter through the occlusion. So I could have taken a chance, try to kind of bury the microcatheter into the lesion, then see if the because I would have used the rotablation or the orbital atherectomy, certainly. Rotablation might have been a little bit more risky because of severe tortuosity, but nonetheless, it can still be used if you're careful and how to handle it in these kind of arteries. And I've done this many, many times. But orbital atherectomy, the same thing. The advantage for orbital atherectomy, I suppose, in this particular case, is the size of the artery is huge. So orbital atherectomy, by higher speed, you could make the lumen bigger. And also you could do the debulking by going back. And often in severe lesions or unbent, you pass the orbital atherectomy distally on Dyna or glide, and then you bring it back to treat the lesion retrogradely. You know, all these, as you know, these are multiple equipment or armamentarium that we have that does help us. As for laser, it is not the first choice in heavy calcium, that's for sure. But many times like this case, because the limitation of rotablation or orbital atherectomy is the flimsy wire that you have to put through. And if you can't put the wire, you can't do it. And this is the advantage of laser. It will work on any wire, angioplasty wire, obviously. And even if you have 1 or 2 or 3 wires, bifurcation or double or like body wire, it still works. With heavy calcium, it's not as effective because of the mechanism, how it works, is the 3 mechanism, photochemical, photothermal, photomechanical. It does not affect calcium as much. However, the number of times that I've used it in heavy calcium, and nowadays I do it with contrast. I know this is kind of not licensed, but we've used it with contrast many, many times. It creates the same kind of shock effect as the shock wave, because these bubbles form up and down, so they break the lesion and modify it. And I think it's very, very useful. Even if it does not go, it modifies the area of resistance, whether it's uncrossable or dilated, modifies it enough to allow you to put a second balloon and treat that lesion. So I think they're all very good. And I am privileged to be in a place where I have all of them. And I have experience with all of them. And I'm the same. I mean, I traveled the world proctoring with laser or rotablation, orbital atherectomy, and laser remains one of the important tools that we have.
Thank you very much for the answer. Of course, from my experience with orbital atherectomy, I always have questioned myself if I have uncrossable lesion, to use it or not. It's sometimes acting, sometimes I have some cases I must switch on rotablation, because orbital atherectomy is not going, but in tortuous vessel, I think it has its place.
I mean, it's a very important kind of note you're saying, because the reason why, just the mechanism and how they work, the rotablation is it's kind of narrow tip. So if there's a very narrow area, with the severe rotation, it could still get kind of hooked into that area. The orbital atherectomy is the orbit or the crown, which is round. So it's severely narrowed, it might not go through immediately. So that's the only difference. And I think this is why I was given a talk recently, I was asked a question, if you were to have any of these, you could only have one, which one would you have? And of course, that's unfair because each one is different and they complement each other to a certain degree. But if I were to have only one, I probably would have rotablation.
I'm the same opinion. Thank you.
May I ask one more question?
Please.
If we have a very resistant vessel, block vessel, how do you choose Alveo 0.75 and the length? Short length, medium length, or long length would give you a more penetration. Which one can you comment?
I think to my mind, intuitively, a shorter one probably gives you more push. Some lesion, the length does not matter, but if there's a lot of resistance, just by kind of, although it's the double fold and the trifold with the more than one might make a difference, but I think often I find the 10 millimeter is probably very, very good. So the shorter one give you a little bit of a push. The longer one might bend or might be a little bit more, less kind of pushable, if you like. And I'd be interested to hear if anybody has a different experience. My experience has always been the shorter, you could push it more. Although on occasion, we know that the metal marker is the highest resistant or the highest or biggest profile. So maybe the longer one occasionally might be better just to get the nose of the balloon in. But in general, to me, is the shorter one. Assuming this is your experience, or do you have a different one?
in my experience, I use not the two-shot one because the same reason as you mentioned. The hardest part is the metal part of the balloon that is in the center of in the middle of the balloon. So if we use the two-shot one, the length that we can dilate will be short as well. So I use around 15 or something to have some part that can get into the lesion. How about your opinion?
Yeah, I mean, I think I don't use any shorter than 10. Quite often, to be honest, if you're finding it difficult passing the 10 or the 15, that means it's the lesion itself, and you just have to be patient and take your time, because sometimes even if the balloon doesn't pass, just the nose of it, you start slowly inchworming your way through the lesion step by step.
Professor, I would like to ask that when you do the granuloplasty before the rotational atherectomy, are you afraid of creating the dissection that will make your rota more risky?
No, to be honest, I don't. First of all, I mean, dissection is probably, it can happen, but I haven't seen it very often. Don't forget that we rotablate in CTOs even if after we have done dissection re-entry, after we knuckled or we use the crosspost. So I think using the dissection with the rotablation, what we should worry about is when you have a big flap and you're trying to rotate, then you tear the artery apart. But in the subintimal space, or if there's a kind of controlled dissection, I don't think it's an issue. In the same token, I don't know if anybody has the different experience. I mean, I haven't seen a dissection from granuloplasty, because these lesions are usually very resistant, and all what you're trying to do is just crack small cracks in them to be able to manage them. But yeah, dissection for me is not an absolute contraindication for rotablation. You could still use it, and I'd be interested to hear what the others think. Is that the same as your experience, Gregors?
Yeah. As well. I'm the same opinion about granuloplasty and the same opinion about rotablation and calcified lesion. And of course, if there's a big dissection, it can be some contraindication, but we must just
in general there isn't.
This is the most important.
Yeah.
So what is the biggest size of the balloon that you use for the granuloplasty?
What's the biggest size? I mean, I've used even up to 3.0, to be honest. Of course, when the bigger the balloon, you have to be really careful, but it's all judicious. I wouldn't be advocating bigger balloons because they could create problems. Usually it's the small balloon, because remember, when you are using the granuloplasty, it's the uncrossable lesion. And often what you are doing with the uncrossable lesion, going to the smallest size balloon. So you're not going to be using large balloon. I have used large balloons occasionally when there's a lot of calcium and a lot of, but carefully, because it's not, you have no control where the balloon will rupture. But for the granuloplasty itself, I think almost invariably, you're going to have very small balloons, the 0.75, the 1.0, or the 1.5 at the most, because these are the lesions that are uncrossable. So you're not going to be trying them with bigger balloon, if you see what I mean.